Hello everyone, I'm Dr. Nandan Marathe. I'm one of the clinical spine fellows at Toronto Western Hospital, University of Toronto. Today I'll be talking about anatomic considerations and functional outcomes of transiliac approach for access to the L5S1 disc and foramen. This research project was conducted under the guidance of Dr. Prasad Padgaonkar, who is the director of the Indo Spine Center. At the outset, I would like to thank the organizers of MISAB for giving us an opportunity to present our work. As you know, transforaminal endoscopic surgery, which was initially described by Cambin, has several advantages as compared to the open procedures. However, the efficacy of the procedure is in doubt when the conventional approach is obstructed by anatomical barriers, such as the L5S1 disc. At this level, we have barriers like the high iliac crest, narrow intertransverse space, wide facet joints, thick transverse process, ala of the sacrum, which make it like a highly guarded fortress. In order to reach this space, various approaches have been described, which include the suprailiac approach, interlaminar approach, foraminoplasty, ventral epidural approach, as well as the transiliac one, each with its own set of advantages as well as disadvantages. The feasibility of the transiliac approach for the L5S1 disc was first studied by Osman et al. In a cadaver in 1997. The authors concluded that the transiliac approach to the lumbosacral junction is safe, and they then replicated the findings of this cadaver study in 15 patients in a clinical study. Dr. Prasad Padgaonkar et al. Described the suprailiac versus transiliac classification system in order to provide the best trajectory to access the herniated disc, and this paper was just published last year. Coming to the methods, our study was carried out over a period of 3 years at Indore Spine Center. Patients with a disc herniation at L5S1 were classified as per the suprailiac versus transiliac classification system, which was previously described by the same authors. Only those patients which fulfilled the criteria for a transiliac approach were included in our study. Here we report the functional outcome data obtained during a 2-year post-op follow-up period. I've included a sample case here. If you can see towards the left is a pre-op MR scan showing a herniated disc at the L5S1 with a large central as well as a left paracentral component. These are some of the intraoperative pictures. We typically use the PLT-OSP as an entry point. To begin the approach, we use an 18 gauge 20 centimeter needle that is followed by sequential reamers, the largest one being 8 millimeters in size. This is then followed by introduction of the scope, which has an 18 centimeter shaft, a 3.75 centimeter working channel, and it's essentially a 30-degree scope. The MR scan towards the right shows the postoperative imaging showing a good decompression. In terms of the endpoint, free pulsation of the neural elements, visualization of the nerve roots, and the patient himself reporting pain relief because he is under local anesthesia are taken as the endpoints. The bottom right, we can see a postoperative CT showing the dimensions of the borehole that is used to access the transiliac space. In terms of results, we had the transiliac approach performed in 62 patients with a mean OR time of 42 minutes with a mean blood loss of just 21 cc. Most of the patients go home on the same day. Some of them do require an overnight stay. The VAS score as well as the ODI score had significant improvements as compared to the preoperative values. In our series, no patient deteriorated neurologically. In terms of complications, we did have one patient with a recurrence at the same level. However, he did not require a revision surgery and could be managed using a selective nerve root block. To summarize, the transiliac endoscopic approach avoids damage to the S1 end plate because it's direct in line with the disc inclination. Disc fragments at various locations can be easily accessed. There is a reduced risk of exiting nerve root injury. It avoids the need for aggressive foraminoplasty and anelectomy. Thus, all the benefits of the transforaminal access at the last mobile segment can be given even in patients with a high iliac crest and the procedure is carried out under local anesthesia, essentially converting it to a daycare surgery. Thank you everyone for a patient listening.